have with me two public health experts, Dr. Chandrakant Lahariya, an epidemiologist, public policy and health systems expert. He's the co-author of Till We Win, India's Fight Against COVID-19 Pandemic book. We also have Mr. Srinath, Reddy, is professor at Public Health Foundation of India. Gentlemen, thank you very much. I know you were frequent invitees 2 years ago, and we were hoping the worries are behind us. But we want to know if it's time to worry again. So you go first, Dr. Lahariya. What's your sense? 1,900 cases, 7 deaths, I believe, on March 25th itself, and two of them in Maharashtra. Bombay and Delhi are reporting higher positivity rates. So is it time to worry?
Good morning. So the cases of COVID-19 are rising in the country is a fact, but this is not a reason to be worried. In fact, I would go back to your slide which you projected that though the number of cases have gone up, but the number of deaths have remained very much stable or stagnant. So that's what it reflects. That's part one. Second part we need to remember is that though cases are rising, and which in my opinion is on expected line. Now SARS-CoV-2, the virus which caused COVID-19, is among us, and time and again we would see such rise and fall. But so we should not be focusing upon the number of new infections, which what is being right now reported. Our focus and attention should be whether a rise in resulting in the increased hospitalization or increased adverse outcomes such as death. And that doesn't seem to be the scenario. Here are two things which we need to remember. One, though cases are rising and globally cases are being reported, but this is the first time on 16th March, World Health Organization redesignated Omicron as a previous variant of concern. So till now, there have been 5 variants of concern globally: Alpha, Beta, Gamma, Delta, and Omicron. But right now, there is no currently circulating variant of concern. First time, no variant of concern currently circulating. All are previous variant of concern. And for the last 15 months, in November 2021, Omicron was reported, which is the last reported variant of concern. Since then, there is no variant of concern. So for the first time, world is without a circulating variant of concern, all are previous variant of concern. That's one. Second is XBB.1.5, though it's a new variant which is circulating. But variants are like 100 plus variants have been reported, 600 plus minor variants have been reported. So every variant is not a reason to be worried. So with putting all of these things together, I would like to summarize this round that we should be prepared for rise and fall in the cases. When cases rise, it's logical that government take notice, start doing mock drills. But for individual citizen, it's not a reason to be worried unless there is a rise in the severe outcome or hospitalization, which doesn't seem to be the scenario. And final point, I would say that we need to remember that what is happening, India has improved the surveillance for influenza-like illnesses or severe acute respiratory illnesses. But there are other countries which are doing little better surveillance. And in some of the United States cities, what had been noticed for the first time in the last 3 years, the cases of other respiratory illnesses are far greater than the COVID-19. So we should not be worried about COVID, but we should be paying attention more to the all respiratory illnesses. And that's what we should be paying attention. So we should be protecting ourselves from all respiratory illnesses. COVID alone does not merit that kind of attention. And it is not a reason to be worried immediately.
Okay. Oh, that's a comprehensive reply, Dr. Lahariya. Dr. Reddy, would you largely agree with what he has said, that we should only worry when hospitalizations increase and, of course, fatalities?
Well, that indeed was a very comprehensive reply, and I fully agree with that. Okay. Let me also add my perspective to it. If you actually look at the cases which are infected by the virus, think of it as a pyramid with a very large base. The very large base of the pyramid consists of people who are infected but never got tested, either because they're asymptomatic or very mildly symptomatic. Then you have a smaller area above that where people who are mildly symptomatic have got tested and are doing well on home care and do not require hospitalization. But at the top of the pyramid are people who have been tested, found positive and have serious enough illness in order to get hospitalized, whether they get into intensive care or not, but they are hospitalized. It is the top of the pyramid that we should be really looking at, because we can never really get a clear estimate of how many people have actually been infected. That depends upon the testing rates and people reporting for testing as well. And of course, there will be some false negatives in testing as well. So it is the top of the pyramid that we must focus on when we are really looking at our decisions on what major policy measures that we must initiate. Of course, individuals who are infected and know they are infected must self-isolate and possibly wear masks at home so that they don't infect others. But it is important for us not to get alarmed, because as Dr. Lahariya said, this is a virus that has now come to stay with us. And fortunately for us, in its present form, it is not very virulent. And therefore, it is likely to be infective, possibly even a little more immune evasive, but not cause serious harm at the population level. But there will be some people who are individually vulnerable, people who have serious comorbidities, particularly elderly, debilitated people or people who are immunodeficient, and they must protect themselves a lot more, taking the precautions if they have not taken, and wear masks, avoid crowded areas, and those are the kind of precautions we must continue to maintain.
Dr. Reddy, take your point entirely. Especially, let me come to that second layer in the pyramid that you spoke about, that some people are find themselves perhaps ill, mildly symptomatic. They take a test. Now, what I want to know is, have we reached a stage where we have to make any of this mandatory? At the moment, a lot of us have a cold and we don't test, and we are probably giving it to others because we are not isolating ourselves. We don't even know we have to. So in the past, at least in my office, it was compulsory to fill the symptoms test every day. I mean, are you coughing? Do you have respiratory problems? Those kinds of things. And if, a larger number of was ticked, yes, we had to compulsorily test ourselves. And if we were tested, we have to show proof of isolation. Do any of these mandates have to be pressed in at this stage?
I think we must give policy advisories and educate people that they must self-isolate if they have a common cold, and put on a mask, particularly when they're mixing with other people. Because otherwise you're going to have a large number of people not even reporting. The importance of testing is really to find out whether there is a new genetic variant that is emerging. And that we can do by testing people in the hospital, because what we are really interested in finding out is there a new variant with greater virulence? And that will land people in hospital. So if you test hospital people, people are hospitalized, then you will get a clue about that. Secondly, you can do wastewater surveillance to find out whether there are new variants that are circulating and which are entered the wastewater, and also get a clear indication of where a new outbreak is likely to erupt. So these are the kind of techniques we need to do. But if you actually make things mandatory, people are going to flout it anyway, and they'll fill wrong reports, and nothing is going to be right.
More than anything else, there can be a fear psychosis. I was hoping that you will, that as well. Yeah, actually, Dr. Lahariya, are you happy with the, as Dr. Reddy said, wastewater area analysis, as well as genome sequencing of people who have admitted themselves? The INSACOG appears to be doing that. I have numbers with me of the number of cases found with this XBB.1.16 variant. Some 97 cases in Telangana, 57 in Karnataka. I think the number is still the highest in 105, I think, in Maharashtra. Is the INSACOG doing what needs to be done? Is wastewater testing also being done, so we don't have to move into this mandatory regime that I asked Dr. Reddy about?
So different testing methodology or approaches has a different advantage at public health level and individual level. So we need to remember that though everyone need not to be tested for COVID-19, but some testing should be continued. So at the broader public health level, we get a sense that whether cases are rising, and so government can alert people and people can take action. But everyone need not to be tested, unlike the past. That's at the individual and public health level. Coming to the genomic surveillance and wastewater surveillance, there is enough evidence which indicate that if we keep doing wastewater surveillance for SARS-CoV-2, actually it can detect the transmission at least 1 to 2 weeks in advance before actual cases might rise. So it's a very relevant and useful approach which is being done in India, and there is no indication from wastewater surveillance data that there is a major rise in the transmission. That's part two. Third, genomic sequencing. Of course, it need to be, one, there should be capacity. Second, there should be sufficient sample from wide geographical area which are collected. Third, what should be the exact number of appropriate or optimal number of genomic sequencing? This is a tricky question. If there is no evidence of new emergence of virus or its variant, then a fairly low number is fine. But if there are evidence coming from other part, you want to scale up. So there is no absolute given number that this is optimal. Unlike in the past, there has been discussion. So what is assuring for India that India is adopting all of these approaches? Individual testing capacity is available widely across the country, and it's a really low cost. Wastewater surveillance is being done, genomic sequencing is being done, and country has capacity. So I'm fairly, I would say, in my opinion, this is fine what India is currently doing. But if there is evidence from any part of the world that there is a new variant which is emerging, then it should be scaled up. And the final point here is that alongside whenever this genomic sequencing is being done, it should be kept in mind the clinical correlation of those sequences with the clinical outcome. And that is what should be studied alongside whatever number we are doing.
Fair point, sir. Out of time, but thank you very much for an extremely comprehensive set of replies from both Dr. Reddy and Dr. Lahariya to the worries that we have. India is prepared. Genome sequencing is being done. Mock drills are being ordered by the Health Ministry. So we shouldn't worry, but perhaps a little more, as Dr. Reddy said,